Hello friends, good evening. This video is on the diseases that affect the neuromuscular transmission. Our main focus is going to be on myasthenia gravis, and we will also have a look at the Lambert Eaton myasthenic syndrome. Both these diseases basically are characterized by the muscle weakness. So let's have a look at myasthenia gravis first. If you are a first year student about to write the exam and it's a short note on myasthenia gravis, you can divide the answer in these four parts: introduction, pathophysiology, clinical manifestations, and the management. So let's talk about them one by one. Now, myasthenia gravis, if you break the word, it tells you the story in itself. Myo means muscle, asthenia means weakness, and gravis means grave. So it's a grave weakness of the muscle. That's the myasthenia gravis. Now basically it's an autoimmune disease. You know what are autoimmune diseases? When the body's immunity starts attacking the body's own cells. So this is an autoimmune disease characterized by profound muscle weakness. Later in the video we will see why there is this muscle weakness. Occurrence about 25 to 125 in every 1 million population worldwide is afflicted by this disease. Peak incidence is seen in women in their 20s and men in their 60s. That is, when myasthenia gravis occurs in women, generally speaking, it occurs in their 20s, and if it is a man which is affected, then generally it is the man maybe in his 60s. Right, that was the introduction part. Now let's see what actually happens in this disease, the myasthenia gravis. The pathophysiology, basically there is formation of antibodies against the nicotinic acetylcholine receptor. You must be aware that on the motor end plate, I mean in the neuromuscular junction, the muscle membrane has these acetylcholine receptors which are of nicotinic type. So antibodies develop against this receptor, and because of this the receptors are either destroyed or the antibodies bind to those receptors and the receptors are quickly endocytosed and destroyed. So basically that's the pathophysiology. There may be a genetic predisposition as well. I mean, in some people it has been found that some family member has a history of autoimmune disease in this case. So that's the basic pathophysiology. There is a role of thymus also which has been found. You know, there are T helper cells which are sensitized against a certain thymic protein. Now these T helper cells attack or they cross react with the nicotinic acetylcholine receptor on the motor end plate. So the T helper cell formed against thymic antigen or thymic protein, and they cross react. Those antibodies then start attacking the nicotinic acetylcholine receptor. What actually happens? Antibodies will bind and destroy some of the receptors. So that receptor population is gone. And they also trigger some other antibodies to bind with the neighboring receptors, and that antibody receptor complex is then quickly endocytosed and destroyed. So almost 70 to 80% of the receptor population is unavailable in this manner, either destroyed directly or antibody binding followed by endocytosis of those receptors. So 70-80% of the receptors won't be available for the acetylcholine to act upon. And that's basically the pathophysiology. Now let's have a look at some physio plus plus. I fondly call it physio plus plus. That is some extra information that will fetch you some extra marks or help you in solving some of the MCQs. All right. Now basically alpha subunit of the acetylcholine receptor. This acetylcholine receptor in the muscle membrane, it has got alpha subunit, and that alpha subunit has got a specific region called as main immunogenic region, MIR. So the antibodies most commonly are known to target this region of the alpha subunit of acetylcholine receptor. This is a physio plus plus. You may always add it in your answer and you get the extra marks. So that's the pathophysiology of the myasthenia gravis. Also, let's have a look at physiology behind the pathophysiology. Let's dig deep into this particular pathophysiology. You know, normally there is quantal release of acetylcholine by the motor nerve terminal. Let's have a quick diagram to illustrate this particular fact. Let's say here is a motor nerve terminal, and whenever the impulse arrives, with one impulse there is going to be almost release of 60 vesicles of acetylcholine, commonly described as a quantal release of acetylcholine. Now what happens is, with the repeated stimulation of those muscles, particular muscle groups, if there is a repeated stimulation, repetitive motor activity, and the quantal release of acetylcholine goes on decreasing. This is in the normal individuals. Okay, so even normally otherwise, with repeated stimulation of the muscles, the quantal release, the release of acetylcholine as the transmitter, goes on decreasing. Now imagine what will happen in myasthenia gravis. The quantal release, if the muscle groups are repeatedly stimulated, the quantal release is going to be decreasing. It's going to decrease. Plus, add to this fact that the receptors are also not available. The receptors have been destroyed. So at one stage, the neuromuscular transmission will just fail to occur. Some of the neuromuscular junctions won't have any transmission. Which means what? Which means, let's say 80% of the receptors have been destroyed in 80% of the muscle fibers. You know, muscle is made up of muscle fibers. So let's say 80% muscle fibers aren't working, they are not contracting. Which means what? Which means the remaining 20% muscle fibers have to perform the function of the entire muscle. And that is going to cause a quick fatigability and a profound weakness. So that's the pathophysiology. Yeah, but just remember over here, quantal release of acetylcholine happens normally. With repeated stimulation, this decrease quanta released at the neuromuscular junction. And now with in myasthenia gravis, with reduced number of receptors, they are not able to compensate for this decreased acetylcholine release, and therefore the muscle fibers will fail to contract. There won't be any neuromuscular transmission possible. All right, let's go further. What are the signs and symptoms? Now basically we've seen that myasthenia gravis is characterized by the muscle weakness, especially by the end of the day, because as I mentioned just now, repeated stimulation, repeated contractions of the muscles, eventually the acetylcholine release will decrease, and therefore receptors are already low in count. That means neuromuscular transmission will fail in a number of fibers in the muscle, and therefore there's going to be muscle weakness, easy fatigability. I told you the reason. Only 20% receptors are active or available in some of the muscle fibers. Let's say in a muscle there are 100 muscle fibers, out of which 80 do not have the acetylcholine receptors, 20 still have the acetylcholine receptors. So those 20 muscle fibers have to perform the job of the entire muscle. That means they are going to fatigue early. So remember those two are the main manifestations of the myasthenia gravis. There are two forms of myasthenia gravis. One in which the extraocular muscles or the muscles involving the eye movement are involved. So it is characterized by the ptosis, drooping of the eyelids, which is called as ptosis. That's a very common symptom or common occurrence in the myasthenia gravis. The other form of myasthenia gravis is the one in which there is generalized weakness. That is, all the muscle groups or most of the muscle groups of the body are involved. So generalized muscle weakness, it's occurring throughout the body. And of course, if there is involvement of the diaphragm, it may result in eventually the eventual respiratory failure. So these are the signs and symptoms of the myasthenia gravis. Now let's come to the management part. Basically, the management involves, the treatment part involves either improve the neuromuscular transmission or at least decrease the immunity part of it, decrease the immunogenic attack on the receptors. So how do you improve the neuromuscular transmission? Cholinesterase inhibitors are the drugs given for this. You know what happens is, normally whenever there is release of acetylcholine and it binds with the receptors, then it initiates the muscle contraction, but then next 150 milliseconds this acetylcholine is degraded by the enzyme cholinesterase. Now if you give cholinesterase inhibitor, that means acetylcholine will not be degraded that fast. I am talking about the treatment part of myasthenia gravis. When you give cholinesterase inhibitors, they will stop that enzyme. That means acetylcholine will not be quickly degraded. It will stay on for longer duration in the neuromuscular junction, and thereby it will achieve two things. One, it will compensate for that decreased quantal release of acetylcholine. We saw just now that with repeated stimulation, the acetylcholine release goes on decreasing. The reduced number of quanta are released. So if the acetylcholine stays longer in the neuromuscular junction, it will compensate for that decrease in the release of acetylcholine. And second effect that is achieved by these drugs, the neostigmine or physostigmine, is that they can, acetylcholine then can diffuse into the neighboring neuromuscular junctions, and wherever acetylcholine receptors are available, the acetylcholine can bind with those receptors and improve the muscle contraction strength. So that's the benefit of giving these drugs. Basically, prolong the stay of acetylcholine in the neuromuscular junction, thereby improving the neuromuscular transmission and thereby improving the overall muscle strength. Then of course, immunosuppression. Steroids, prednisolone, it's going to suppress the immunogenic attack on the acetylcholine receptors, and thereby it will have then good number of acetylcholine receptors may still be available for transmission. The third type of treatment is a surgical way, thymectomy, removal of the thymus. We have seen already that there is some thymic antigen or thymic protein against which the T helper cells are formed or sensitized, and then those T helper cells cross-react with the acetylcholine receptor, destroying that receptor. So removal of thymus helps. In fact, in many of these patients, there is a presence of thymoma, and that also is partly responsible for the occurrence of myasthenia gravis. However, thymoma or no thymoma, removal of the thymus does help in a number of patients of myasthenia gravis. So that was in a nutshell the myasthenia gravis. I remember whenever I asked this question to students, first year students, they may or may not recollect all of this, but they certainly recollect that a mega star, a film star from Bollywood is suffering from myasthenia gravis. I'm sure you know who I'm talking about. But anyways, whatever it may be, remember all these facts and you are going to get maximum marks, almost full marks in any short note in any exam. So that was myasthenia gravis. Now let's also have a look at the other disease that we were talking about, and that is Lambert Eaton myasthenic syndrome. Now you are aware myasthenia or myasthenic means muscle weakness. That is, now you are very well aware of that. Now this again is an autoimmune disease, just like myasthenia gravis. But this time, I mean in this disease, antibodies are developed against voltage gated calcium channel, to be more precise, CAV 2.2. Where are these channels present? Let's have an illustration. This is the motor nerve terminal, and in the motor nerve terminal there are these voltage gated calcium channels. Whenever the impulse arrives, these channels open, there is influx of calcium into the terminal, and only then the acetylcholine is going to be released. That's the normal case. So that is why we require these voltage gated calcium channels. But now in the disease LEMS, the Lambert Eaton disease, many of these voltage gated calcium channels are destroyed due to the antibodies. In an autoimmune fashion, these antibodies are developed against the calcium channel. The other thing that has been observed is that there is a strong association with cancers. I mean, the people suffering from cancers, they have been shown to produce these antibodies, particularly small cell carcinoma of the lung. This is a cancer that is has been shown to produce these antibodies, resulting in muscle weakness. Now the Lambert Eaton disease generally involves proximal muscle groups of the lower limbs, and because it involves those muscle groups, generally the patient presents with a waddling gait. The gait is disturbed. Apart from that, if the upper limb muscles are involved, then the patient might find difficulty in raising the arm. So these are the common symptoms of Lambert Eaton disease. Now, one thing that should be understood clearly, it's a distinguishing feature, that is, repetitive stimulation of the muscle would result in increased strength of that muscle contraction. Let's compare. In myasthenia gravis, repetitive stimulation of the muscle, and as I mentioned already, the quantal release of acetylcholine will go on decreasing, and therefore there will be decreased strength of the muscle contraction. In this case, in the case of Lambert Eaton disease, with repetitive stimulation, the muscle strength will improve. Now the question is, why is that? What happens is, although some of the calcium channels in the presynaptic terminal have been destroyed, many calcium channels are still available. Calcium influx happens. Now if you cause a repetitive stimulation of particular muscle groups, then the calcium will keep coming in from whatever channels are available, and at one stage the calcium is accumulated in the motor nerve terminal, in the presynaptic terminal. So there is calcium available, and you are aware the amount of neurotransmitter released, the amount of acetylcholine released is proportional to the amount of calcium available in the presynaptic terminal. So suddenly what is going to happen is, after repetitive stimulation at one stage, calcium will be available in greater amount. Therefore, there will be greater release of acetylcholine and more number of fibers will contract and the muscle strength will suddenly improve. So that's a distinguishing feature. So far, if you get a short note or a short answer question, compare and contrast myasthenia gravis versus Lambert Eaton disease, you can mention at least two differentiating features. One, myasthenia gravis involves the acetylcholine receptors on the post-junctional membrane or motor end plate, whereas Lambert Eaton disease involves the calcium channels in the presynaptic terminal. And the second one is this: repeated stimulation, the contraction strength will decline in myasthenia gravis, but it will improve in Lambert Eaton disease. So that was Lambert Eaton disease. What's the treatment? Again, treatment is along the similar lines: prednisolone or steroids for immunosuppression. Plasmapheresis, plasmapheresis is generally done to remove the antibodies from the serum. There are antibodies in the plasma. They can be removed by this procedure, the plasmapheresis. And aminopyridines, these drugs are sometimes used in the Lambert Eaton disease. What's the basis? These drugs are known to inhibit the potassium channels. Potassium channels in the motor nerve terminal, presynaptic terminal. Okay, not calcium. Potassium channels are inhibited. Now, because the potassium channels are inhibited, the membrane voltage shifts a little bit, and that activates the calcium channels which we are talking about here. So, these drugs, by inactivating the potassium channels, they trigger the activation of calcium channels in the presynaptic terminal, and thereby the condition improves. So that's the Lambert Eaton disease. Now, having discussed all of these features, and the disease is related to the neuromuscular transmission, finally let's have a look at an MCQ which I had posted today, and I expect all of you to answer in the comment section of this video. You may answer this MCQ. Myasthenia gravis is an autoimmune disease characterized by profound muscle weakness. Now, flux of ions is diminished through which of the following channels? I have not mentioned it in the video. I just mentioned that it is the acetylcholine receptor which is damaged or destroyed. But there is a channel associated with this receptor. This channel opens and there is flux of ions normally, and that results in the muscle depolarization and resulting in muscle contraction. So the question is, what is the channel that is associated with the acetylcholine receptor? Receptor portion is one portion, the other portion is channel. What is that channel typically? Okay, so the options are: is it a non-specific cation channel, or a voltage gated calcium channel, or a voltage gated sodium channel, or a ligand gated calcium channel?